Hi, everyone. Thanks for joining us today as we dive into the cognitive changes that come with normal aging that can potentially begin during your menopause journey. My name is Kim Fancher, and I'll be your host today. I'm so happy to have Dr. Dona Murphey with us today to share her knowledge and her expertise on this topic of cognitive aging. And some of us may be personally experiencing it now, or possibly know someone who is, or even have a loved one that you care for that is showing signs of potential cognitive decline. And we hope that this high level exploration today will help you better understand some of this and how certain things can be considered to possibly even slow down the progression. I'd like to introduce Dr. Dona Murphey, who is a neurologist, a neuroscientist, and community health worker in Houston, Texas, and Seattle, Washington. She has over 10,000 hours of community organizing experience at the intersections of race and immigration, poverty, and health. And she serves on the Area Planning Advisory Council of the Area Agency on Aging, and also brings experience in providing diagnostic services in clinical trials and drug development for brain disorders to her work in the family caregiving support for dementia. So thank you so very much, Dr. Murphey, for being part of our Positive Health webinar series. And your work is so extraordinary. And I was wondering if you could kick us off by telling us about your career and how you got started in this space.
Sure. So yes, as you mentioned, I'm a neurologist and a neuroscientist, and I guess started as the medical and scientific director of an EEG company. It was a startup company at that time, and we grew to be, I think now, since I've left, they have become and sustained, I think, their position as one of the largest, if not the largest, provider of EEG services in ICU patients. Um, we started getting involved in clinical trials at that time. I've since left that company a few years back and started Prognosis, really thinking to marry my interests and values to the work that I do as paid labor. I was serving on a lot of nonprofit boards, doing a lot of community organizing and grassroots activism through the pandemic and prior to the pandemic, and figured that it would be easier to actually integrate those activities with what I get to do for my job. And so I find myself now spending most of my time with my own social impact company, which I started in 2021, I think officially in 2022. And that is Prognosis, where we support the family caregivers of people living with dementia, with a particular interest in supporting those families who are unable to access the appropriate health and social services that all of us deserve to access in navigating this very difficult and often very long journey with this condition. So today I wanted to talk a bit about what dementia is, how we can tell the difference between dementia and the normal cognitive changes that you might see in aging in general. Why we need to be able to tell the difference, right? What are some of the things that we can do to prevent the onset of this disease and also to delay the progression of it, which is actually really, really important. I think we underemphasize the importance of delaying progression, which we have a lot of control over. And then also, I think importantly, and you're going to hear throughout this talk, the importance of cultural fluency and also language specificity in meeting the needs of our diverse communities. So I'll just get us started with some of the objectives that I hope to meet by the end of the talk. So I want to make sure that all of those who've joined us today or who are watching this afterwards can distinguish between these cognitive changes that we see in normal aging and dementia, that everybody can identify these 14 modifiable risk factors that have been defined in dementia in order to prevent the onset of the disease or to delay its progression. I hope by the end of the talk that everybody understands the importance of cultural fluency and how difficult it can be when we are not mindful of cultural fluency in everything about dementia. And also, I wanted to ensure that we think about these areas, these specific areas, which I think are neglected in cognitive in understanding cognitive change in people, right? And long COVID is one, and I have a lot of advocacy experience in that, and also education experience in that. And menopause is the other area. And I will be maybe talking about those things throughout the talk as well a little bit. So now I want everybody here to ask yourselves the question of whether you know anyone exhibiting what you would consider cognitive changes of normal aging. And think for a second about those individuals. What kinds of signs, which are things that you notice, or maybe symptoms, have they shared with you? Do you think are normal? And what things do you think are problematic? Next question I want you to consider is, do you know or care for anyone with dementia? Right? They may have a formal diagnosis in which case you can be a little bit more certain that that is in fact what they have, or they may have dementia because, people collectively understand their symptoms and signs as dementia, but they don't actually have a formal diagnosis. Right? So think now about what those differences are between those individuals that you've kind of seen in your mind's eye. Now we're going to talk about what the difference is actually between these two things, because for a lot of us, and I think even for me, I have to kind of remind myself of like, how can you tell the difference? There is a lot of overlap, and a lot of what allows you to see the difference between one and the other has to do with what happens over time. But some of it has to do with the specific kinds of symptoms that you see. But you'll see that there is a lot of confusion because of the overlap in the signs and symptoms that you may observe in both. So the brain changes in normal aging. The big takeaway message here is that they do not interfere with independent activities. Okay, so if you observe any of these things or other behaviors, if they do not interfere with that person's ability to function independently, then it is probably part of normal aging. But the caveat is that you have to see what happens over time. So let's look at some of these things, right? Slower processing speeds, right? It takes you longer to think through a problem, less capacity for multitasking. I will say that both of those things I have found to be true of myself in my 40s. Mild attentional deficits, mild word finding difficulty where you might not be able to identify exactly what you want to use in communicating an idea, but it comes to you maybe a few seconds later, or you're quickly able to use a different word in your vocabulary to communicate basically the same idea. That's not too worrisome. Mild working memory difficulty. Right. So if you're, I don't know, performing a simple math problem or something like that, right? Like having a little bit of trouble with that, but being able to get through it. Maybe you're a little bit slower. So these things are not too worrisome. Brain changes in dementia can be different. They also can be things that have progressed more substantially to where they are actually interfering with independent function. So short-term memory loss that disrupts daily life, right? So we did say that memory is impacted in normal aging as well, but very minimally impacted and kind of in transient ways too, right? To daily life. And then trouble planning or problem solving. Again, all of these things, as a reminder, interfere with your independent function, so that you need someone else to start helping you with some of these items, or you lose track of them to where, they're really disruptive to your life. Trouble with familiar tasks, that is pretty distinct. That does not really happen in normal aging, right? So if you have known how to use a calculator or a computer or play solitaire, like on the computer, for instance, for many, many years, and now all of a sudden you're kind of not able to do that. You don't remember how the remote control worked. You don't remember how to use the microwave, things that were very familiar to you. That does not really happen in normal aging, right? So as I said before, there are some of these symptoms that are kind of peculiar to dementia and maybe would make you a little bit more concerned. Confusion with time or place, again, something that does not happen in normal aging unless you're, intoxicated or something like that, very, very sick. You shouldn't ever be confused with where you are, or, like kind of the approximate time of day. You might not know exactly what time it is. Trouble with visual perception also is peculiar to dementia. You shouldn't really see that with normal aging. Now, where this can become confusing is that you may have glaucoma, right? Or diabetic eye changes. And the reason you have trouble with visual perception has to do with your eyes and not necessarily your brain. When we talk about trouble with visual perception in dementia, we are more so talking about how vision is processed in the brain. And so your perception is altered. You have a kind of a narrowing of your field of view. Withdrawal from work or social activities. And this can be for a number of reasons in dementia. It could be that people are realizing that they're having some of these cognitive impairments, and so they are ashamed. They're worried that people might notice. And so they may feel less inclined to be involved in social activities. It may be that that this is actually part of their illness, that they don't want to actually participate in those activities. Interestingly, when I had a conversation with a patient in a care dyad, so it was the caregiver and the patient, about why they felt less interested, and this was the case for her, in being engaged socially. She used to be very, very social. She very happily offered that it was like, it's not that she's embarrassed. She actually is kind of aware that or at least she's aware because people tell her, right? I don't know that she recognizes it about herself, that she's forgetting things, but she doesn't claim that she's embarrassed about any of it. She says that she simply is not interested in engaging in those activities anymore. It's just a change for her, right? So that may be the case. It may depend on the individual as to what the reason is, but this is in fact something we do observe. In normal aging, you might also see this if people are showing some depressive symptoms, whether they have major depressive disorder or not. They may also not be as interested. They may be upset and they don't want to be engaged anymore because some major life change has happened, right? Maybe they don't have a diagnosis of anything, but they're withdrawing for that reason. So again, there is overlap with normal aging. New problems speaking or writing. Those also can be a little bit peculiar to dementia, depending on what that actually looks like. So yeah, again, for some of these things, it's really a matter of tracking them over time, but you don't want it to get too far along because you kind of narrow the window of opportunity to actually intervene. If it actually is dementia in development, you're losing time. We always say in neurology, neuroscience, time is brain. And so, you don't want to sit on this too long. Misplacing things or losing your way, that's very common in kind of Alzheimer's dementia. You hear about people wandering or getting lost with this disease. Decreased or poor judgment is another way this shows up, and then also changes in mood or personality. This is actually a bit tricky because people can have depression as a risk factor for dementia, but it can also be something that occurs at the same time as dementia. And can be something that gets confused for dementia. And so you have to be careful here. And this is why at the end of the day, it really helps to have a formal diagnosis because I think as people who are not trained in medicine, we may have a lot of trouble discerning, right? But again, the key difference is that this does not interfere with independent function if you're experiencing cognitive changes of normal aging, but these symptoms we do see interfering with those independent activities if what this is dementia that we're observing. These symptoms also cannot be better explained by another mental disorder. So again, when I mentioned depression being confused for dementia, right? This is something that we have to rule out as physicians, because it might be the case that the person is having a little bit of trouble remembering things because maybe they're not so motivated. They're also just, very upset and, spending most of the day in bed. They could have depression, in which case we can't diagnose dementia if we can treat that depression and it gets better. Now, if we treat that depression and it doesn't get better, it could be the case that this is actually dementia, right? So there are some things we have to do in terms of diagnosis and treatment sometimes to really figure out what's going on. Also, the last thing I want to say here is that when somebody is delirious, and that means that they are kind of acutely or like in this moment, a lot different cognitively, right? Maybe they're hallucinating, right? They're agitated. But this came on suddenly. They have a cough and fever, right? Like maybe they've been hospitalized and they're in an unfamiliar environment. In that setting, it's not appropriate to make a diagnosis of dementia. Now, prior to that, if there was already a history of somebody having some of these cognitive symptoms I mentioned, and those things have actually gotten worse over time, they could have both going on. It's that they have delirium on top of dementia. right? But you cannot, if you don't have that history, you cannot say that these symptoms in this window of time diagnose as dementia, even if they meet the criteria in terms of the symptoms and the signs, right? Okay, so does this difference matter? It matters because the difference between normal aging, right, and cognitive symptoms experienced in normal aging and dementia are profound. So here, when we look at the costs of somebody who has normal, kind of progression of their life, right, with whatever cognitive symptoms that may entail, versus dementia, you can see like the lower bar on each of these graphs is representing kind of the person without a diagnosis of dementia, and the upper bar is representing the people with a diagnosis of dementia. These are showing you what happens in the cases of people who are, they have this diagnosis at the age of 90 versus 83 versus 75. And as you might suspect, the person who gets this diagnosis earlier, presumably living still, a decently long life after the diagnosis, which is often the case for people with dementia. You can live, sometimes it is abbreviated, 5 years, 3 years. Many times it's 10 years, 15 years, 20 years even with this diagnosis. So at 75, if you get this diagnosis, you can see this is super expensive. It's over $500,000. Much of that cost is actually assumed by the informal caregiver, which in the vast majority of cases is unpaid. In 2/3 of cases, that person is a woman. A lot of out-of-pocket expenditures in this next kind of darker color represented here. And then these two other boxes are showing basically publicly financed healthcare that is required for this older individual. This also we have to be, thinking about when we see this disinvestment in publicly funded healthcare. This is now going to become the responsibility of patients and their families. So $500,000 with someone who has an incident case at 75, and you can see it goes up from there. And relative to that person who does not have this diagnosis, it is a very big difference. You can see that the difference narrows the older we get, right? Which makes sense because there are other reasons for utilization as we get older with all of our other chronic ailments. But this is really concerning, and this is a reason why you might want to identify this disease earlier, because you can slow down the progression of this disease so that it doesn't have such profound costs, actually in every dimension, not just financial, but emotional, social, physical. So here you can see that, tons of money is forfeited. And the unpaid labor that we provide as caregivers. I'm a support caregiver to 4 people in my family, so I very directly live this in many ways. And this is, yeah, as I said, it is not representative of all of the costs there are that are really incalculable with how challenging this disease can be. When there is diagnostic delay, so i.e., when we don't have an educated population of people who understand the difference between cognitive changes of normal aging and dementia, they're not going to be motivated to present to the doctor or to go with their loved one to the doctor to express some concerns because they don't know the difference, right? When we have a diagnostic delay, we end up having this enormous cost for some of the reasons I mentioned before, right? You are forfeiting the opportunity to actually intervene early to slow down the progression of this disease. And there are a lot of other things that you can put into place in order to mitigate the costs of the disease. As an example, if you know early that you should get a durable power of attorney in place for surrogate decision-making, right? Because this is a disease fundamentally that actually reduces our ability to live independently, to make our own decisions, including financial and legal decisions. If you don't have such paperwork in place and this disease progresses, your family may have to fight for guardianship in order to make financial and legal decisions for you, right? This is a whole process. It's expensive. It takes time. It can be contentious within the family. So many other costs. And that's just one dimension of the care that is required for people living with dementia. How can we change these outcomes? So I think it really kind of irks me that we have, even though I've demonstrated to you how challenging the disease can be, that we have this perception that we can't do anything at all because there is, quote, no cure, right? That is true. There is no cure. There is nothing that actually stops the progression of this disease entirely. There is nothing that reverses the lost function. Definitively. I will say there are some caveats to that because sometimes people will see like recovery of some function, especially if it's for like a discrete period of time. But what you see when you zoom out is that there is a decline over time, even if there is some volatility or variability. There is a decline gradually over time, but we can change the outcomes. How can we intervene, right? Here are the 14 modifiable risk factors of dementia. 40% of all dementia can either be prevented or the symptom signs and their progression can be delayed, right? The best situation, if you have a diagnosis of dementia, I have a family member right now who has mild cognitive impairment, right? This is the precursor to dementia. It does not always progress. And I will show you in a moment some slides that illustrate this. But often it does because people are not taking care of these risk factors. And we have control over all of these things with maybe the exception of air pollution here. We don't have individual control over that. We, have, I think, a collective responsibility to ensure that policies keep us safe from environmental pollutants. But everything here is kind of within our ability, right? We have control over these things. And I will say, if you have any of these risk factors, hypertension, diabetes, or high blood pressure, diabetes, obesity, um, if your cholesterol is high, if you're a smoker, if you're drinking alcohol, any of these things, it's not that, having it means that, okay, you can't address that risk factor. Even control of those risk factors. So if you're well controlled, you have a diagnosis of high blood pressure, but you're doing your daily blood pressures, you're on blood pressure medication, you're losing weight, you're eating right, and your blood pressures are well controlled, even though you have high blood pressure, it's well controlled. So that's the best you can do. If these things are not well controlled, you have some work to do. And that really actually does make a very important difference in the progression of this disease. And like I said, if you don't yet have it, it can be really key in preventing onset. Less education. This is supposedly less formal education, though I will say that many people don't have the opportunity. This is where cultural fluency is important, right? Many people don't have the opportunity for a formal education. If you are reading, if you are challenging yourself to learn new things and think more expansively and in a more integrated way, reading is key for a lot of this, right? Not social media consumption or, videos on YouTube. Reading is really important for this. That can also be protective. I will say with the caveat that there isn't a lot of research on what I'm talking about. The formal guidance is that formal education is what actually protects you. Physical inactivity, kind of like all of these risk factors that are called cardiovascular or cardiometabolic risk factors. Also, if you're not physically active, that also will put you at increased risk of dementia. These things also put you at increased risk for heart attacks and strokes. So it helps to address these issues, these risk factors for many reasons. So social isolation, we saw during the pandemic, is actually super impactful. It accelerated the diagnosis of, or accelerated the decline with people who already had dementia. It made people develop dementia also, and that social isolation, who did not have a diagnosis prior to the pandemic. Hearing loss and vision loss are interesting because they are, maybe contributing to the risk of dementia for sure. There's evidence that they contribute to the risk of dementia. It might also be that people are not able to engage socially as much, so it has an indirect impact on social isolation because they can't see things as well. They can't hear the conversation, right? They cannot be engaged fully because their sensory systems are not fully functional. Traumatic brain injury, that also puts you at increased risk if you have a history of having, concussions, right? If you played football, right, and had head injuries there, or traumatic brain injury or concussions there, that actually will put you at increased risk. The more severe and the more repeated the brain injury, the greater the risk. Again, depression is a risk factor as well as something that gets confused for dementia and something that can also co-occur with dementia. And then the last point I wanted to make here is that these risk factors are racialized. Many of these risk factors are either they have greater incidence among people from communities of color for a number of reasons. I think most of us agree that that's largely driven by social determinants of health and not any kind of genetic predisposition. But it could also be access to appropriate care, right? Culturally fluent care, language specific care. When you don't have that, when you're for many reasons, historic and contemporary, not willing to go to the doctors that are available to you, then, and that's that's not your fault. That's the circumstance, right? You may find also that if you're from a community of color, that you are disproportionately impacted then in some of these domains. So it's really mindful to think about. It's really important to be mindful of that, so that we can be, I don't know, make extra effort, I think, as individuals, as health advocates for ourselves and for our families, but also in terms of kind of making collective change so that we can resolve some of those broader issues. So moving forward, we don't continue to have those kinds of structural barriers. The incidence of dementia is racialized. If you are Black in the United States, you have 2 times the incidence of this disease as non-Hispanic whites. If you are Latina, you have 1.5 times the incidence of this disease as non-Hispanic whites. If you're Indigenous, we think you're probably somewhere in this vicinity as well. Maybe closer to this number. If you're Asian American, unfortunately, because we don't disaggregate information, we don't disaggregate that data for Asian Americans is just one umbrella category. It's hard to really know what's happening there. There are some studies that say that as an aggregate, maybe there's slightly increased incidence, maybe it's about the same as non-Hispanic whites. But when there are attempts to disaggregate the data, it does look like there are specific vulnerabilities with specific Asian populations. So this is also really important to think about, right? This is what happens to dementia over time. Normal aging, right? We're in our 40s here. At the end of our lifetimes, if we live to be, the average age of a person across all, races and other demographic categories, the average age of a person in the United States, somewhere in your 80s, right? We live to be somewhere in our 80s. By that time, 2/3 of people will not have dementia, but 1/3 of people will. As I mentioned before, this mild cognitive impairment does not always progress, right? If you're lucky, that does not ever become dementia, right? You've slowed down the progression enough, right? So that or the potential progression enough so that by the end of your life, you hopefully die a peaceful death and you never had frank dementia that was functionally limiting, right? Or impairing your independence. But many of these people, for the reasons I mentioned, because they're unwilling to address some of these chronic risk factors, or to control them adequately, right? Or to prevent them, they are experiencing the progression of this spectrum. This journey is also racialized. I started with those modifiable risk factors, but every aspect, if you want to get involved in clinical trials, we have these new monoclonal antibodies that, they have recently approved. People are looking at a lot of different mechanisms of how this disease comes on and how it progresses, and they're doing studies. We need those studies to be representative of the populations that would be ultimately taking those drugs. But clinical trials still is like that whole ecosystem is still grappling with how challenging it is to involve, to empower people from communities that are disproportionately impacted in their trials. Finding the appropriate diagnosis, counsel, and care when you don't speak English, right? Like my family member had trouble with this, finding somebody who speaks Korean, who could speak to them directly in a language that they prefer, right? Not that they don't understand English. That's really difficult. And this is a disease where, you need that kind of guidance. You need to be able to connect. You need to get a message from your physician that is emotionally resonant. It's a really hard disease, and to not have that available to you makes it all the more difficult. Even at the end of life, in hospice care, we see disparities, both in who can access what quality of care and the kind of care they receive in those institutions. There are racialized health disparities. Research along this whole spectrum in terms of basic science research, also problematic in terms of the lack of representation in those involved in that work. This is just a comment that I want to make about having no cure in dementia. What does that mean to me and to kind of the social impact company that I built? It means that we focus on relationship as the principal thing that we have to invest in, that is healing, right? Where you have no definitive healing per se. It is relationships with other caregivers, people who understand what you're going through, with your family members, how you are collectively understanding the loss of who someone fundamentally is, right? And how you were having, how you were coming together to care for that individual, the relationships that you have with clinical people who can help you with some of the clinical issues that come up, the challenges that come up when your loved one is no longer safely swallowing, right? Like, what is the nature of that relationship? Is that someone you can trust, right? Um, those things actually matter a whole lot. I mean, they matter a whole lot when we have a definitive cure too, but in the case where you have no cure, that actually becomes central and absolutely vital. Um, Here you can see that I share some of the people who have contributed to our efforts at Prognosis, and these are our caregiver storytellers. I'm one of them. But we have Flor, who was 13 when she became a caregiver for the first time for her mother. They were undocumented. She was Spanish speaking, like very little English, lived in the Valley in South Texas. They were without any kind of publicly funded healthcare access. Her siblings, who still lived in Mexico, told her that she really needed to take care of her mother when she had her first stroke in what would become a series of strokes and vascular dementia. She now helps to care for her father-in-law. Her husband is his primary caregiver, but she lives there in the household with her husband. And now I think her father-in-law is in an apartment nearby with some hired folks who are helping, professional caregivers who are helping them with that. Her situation has dramatically changed over time, but in terms of her ability to care for her mother with all of those challenges to begin with, and now later in life, facing again this disease, her resources are a lot different. But what she will say is that the emotional experience and some of the challenges that they face in terms of systems challenges haven't changed much. And that tells you something, right? Like, we're all in this very difficult journey together. And I think it's easier to think about it in terms of being in it together than to think about doing it all on our own. Um, this is just kind of touching upon all of the different social determinants of health. So each of their stories in our story library, which you can find access on our website, tells a lot more about who each of these individuals are. Jessica took care of her mom while she was working. She talks a lot about kind of juggling that experience, being able to pay for care. Diane is a pastor whose husband also was a pastor, and he had Lewy body dementia. They were living in Detroit at the time that she talks about kind of the challenges of like the household environment in terms of safety, home safety for somebody living with dementia, and also for the environment at large, right? Like, our communities are not built for people who have dementia. That's why we worry about our loved ones wandering into traffic, right? Onto highways, driving. Um, yeah, so she talks about some of those challenges. Connie talks about clinical trials and some of the racism that we've seen historically that really dissuade people from enrolling in clinical trials from communities of color. But furthermore, really have built a kind of distrust against the whole like medical industrial complex, right? So she speaks a bit about that. I speak about bilingualism in dementia. Language in dementia is super interesting. If you speak more than one language, it can actually be protective. It delays the onset of dementia by 5 to 6 years. But what happens also with language and dementia is that if you speak multiple languages, as the disease advances, you no longer speak the acquired languages as well, right? Your primary language is the one that you kind of revert to. What that has meant in my family in terms of kind of emotional impact, and for me, is that I grew up here in the United States at a time when people said that we should assimilate all people of, immigrant backgrounds. And part of that assimilation is language assimilation. Like, don't speak that language in your home because these children are not going to learn English. And so, my parents followed that advice. And what it did was to create a division between me and generations prior, namely my grandparents' generation, because they had the most to work to do to acquire English as much as they could during their adulthoods. And now I'm not able to communicate with them very meaningfully through words. As dementia progresses, our loved ones lose their words too. And so communication starts to look a lot different, right? And so now we've kind of come full circle, and where I'm able to communicate again, but not through language or not through spoken language. So yeah, all of these kinds of like, really, I get tearful actually thinking about this. All of these kinds of issues are so emotionally charged. And I think this is the kind of culturally fluent counsel and support that we are missing in a lot of the support that is offered, I think, to people who get this diagnosis and their families. Cultural fluency shapes how we care for people, right? It shapes the ability to access services in language, Symptom presentation can actually vary across cultures. So it might look different, right? Um, how a particular symptom of dementia presents in one culture versus another. And that's important to be mindful of because you may miss it as somebody not being from that culture. So when that family comes to you, as if there are any clinicians in the audience, right, saying that something is wrong, right? Um, we really should take that very seriously because people know their loved ones best. And also they come presumably from the same culture and would know, if some of these differences or maybe impediments are to diagnosis, they would not be facing some of those same challenges. And so we should be listening to those family members. Beliefs about aging can also be different across cultures and how much we actually expect of family members to kind of step in as our needs change with aging, whether they make us no longer independent, as with dementia, or even just in general, like as we age, even those of us who remain like pretty independent still need some help. And how we think about that culturally, I think, is really important. Understanding of dementia also, because this is in some cultures thought to be, just being crazy. In some cultures, it's just thought to be normal aging. Everybody goes through that. And we saw from the numbers that not everybody goes through that. Caregiving norms also can be different across cultures and expressions of grief. Grief is a very distinct experience in dementia because we actually are kind of grieving throughout the course of the disease as we lose our loved ones in pieces, basically. And then there are all of these structural issues that I think I already alluded to, also super important to consider. Being able to speak to these, like casually or more formally, I think is validating. I think is empowering. We need to be able to do that with the families that we work with. And the last comments I wanted to make here have to do with long COVID and with menopause. So I wanted to just share a little bit about the symptoms we may see, right? And I put this in different words here, but some of these are very much overlapping with what I presented to you in terms of the symptoms that you see in dementia. And they're very much overlapping with the symptoms that you may see in cognitive changes of normal aging. Again, the difference being that in dementia, you see a progression over time, and it is the loss of independent function. And in normal aging, those cognitive changes do not impair independent function, right? But a lot of the symptoms are the same. So if you just have a snapshot, I mean, gosh, is it COVID? Is it menopause? You're about to see on the next slide. Is it menopause? Is it dementia, like in evolution at the beginning of the disease? Is it just what happens to us as we age and it's normal? We don't actually know with any single snapshot in most cases. I did tell you there's some things that are kind of redder flags in those symptoms of dementia than other symptoms, but often it's a confusing picture. So same thing here with long COVID. But I think when you've ruled out other things, and this is why formal diagnosis can be really helpful. And long COVID is kind of this, what we call a diagnosis of exclusion, right? The doctor is really trying to figure out, do you not have these other big bad things, right? Once they've ruled those things out, if you do have a history of COVID, maybe if you had a severe COVID infection, especially, then they might say, like, this is maybe what you have. What can we do to mitigate like these cognitive symptoms? There are compensatory strategies, of course, like, you can write things down. You can start using a planner if you didn't use that before, reminders. You can use apps, right? So there are lots of things that you can do. I've told colleagues of mine, hey, sometimes because I've had long COVID, sometimes I'm gonna need you to understand that I did not intend to do it, but I double and triple book myself even. And so I have to then go back and scramble to get out of meetings or to reschedule meetings. And I'm profusely apologetic, but I set that expectation early. And that's this next thing here is if you set that expectation with yourself and with people around you, I think that is enormously helpful. Because then you don't end up disappointing yourself and others, right? Peer support is really, really helpful. I plugged into Facebook communities. There was a Slack community for long COVID for many years. That was enormously helpful because these are people going through it, at the same time as you are. And it's really helpful to learn from one another, to understand that you're not alone. Addressing polypharmacy. The older we get, the more medications we get put on. Certainly, if you have long COVID, on top of that, you may find yourself on many medications because this can often be multisystemic. These are just the cognitive symptoms, but there are, I mean, I have some chest discomfort. Sometimes I have shortness of breath, right? So there are other systems that are involved, and you may get put on multiple medications that have cognitive side effects. So, you want to look at those drugs to see what do I really need here, if this is impacting my ability to think clearly. The one thing that's distinct for long COVID is it helps to balance activity with rest. So really, trying to chunk your time such that you're not doing prolonged activity. And I don't mean physical activity only. I mean also mental activity. That can really interestingly be physically exhausting when you have long COVID. It's a very well described phenomenon. And so balancing that activity with rest is really key. The distinct risks for actually developing long COVID have to do with the severity of the disease that you have. So if it required hospitalization, you have a greater risk of developing long COVID and experiencing some of these and other symptoms, right? The interesting thing is that even if you're not hospitalized, even if your symptoms are not in any way severe, like they might be super mild. In some cases, people are asymptomatic, but they're infected. You can still develop long COVID. The odds are lower if you don't have a severe disease. I did not get hospitalized. I did not for most of the course of my condition, I did not consider it super severe. I was sleepy. I was very sleepy. And there was one day where I had extreme pain, like GI pain, but it was not severe mostly. And yet I very much had these symptoms for years. Prevention of decline, always, I'm going to say there's 14 modifiable risk factors. It does appear that long COVID is at least in part, due to cardiovascular changes. And these modifiable risk factors, they're speaking to a lot of the same risk factors that cause cardiovascular disease or events, right? Like strokes and heart attacks, as I mentioned. Dementia is also related to that. Sleep is really important also for addressing some of the symptoms that you might have here with long COVID. And then finally, the last slide is about menopause. These are kind of unchanged symptoms, very much overlapping, identical in this case with long COVID, right? And very much overlapping with cognitive changes of normal aging and dementia. Mitigation, very similar. The one thing I didn't include here is the balancing rest with exercise. Like that particular strategy is a little bit distinct for long COVID, but always you should rest, of course. That can always be helpful. Sleeping and addressing the modifiable risk factors of other kinds of cognitive conditions like dementia can always help. So do that. And then the distinct risk here in menopause, and I encourage you to listen for more information on this to the podcast that I did with Positive Health as well, is early menopause. So whether that is chemically or surgically induced, or occurred naturally for some reason, the risk, it's pretty definitively higher for dementia for those individuals. If you have menopause starting at kind of the normal range of ages, it does not appear that there is a definitive correlation between cognitive symptoms of menopause and dementia. That being said, women are more likely to get dementia. So there are hormonal factors there that are likely contributing. That's not considered one of the 14 modifiable risk factors disease, anything having to do with, estrogen and progesterone. But we may find over time that there is something there because there is a vulnerability that appears not just to be an artifact of women outliving men, because the older we get, we also have an increased risk of dementia. But it does appear that there is something hormonal there that is related, but there's nothing definitive about menopause and cognitive symptoms in menopause being definitively related to dementia. So nothing to fear there. I'll stop there and open up for questions and answers.
Yes. Well, thank you so very much, Dr. Murphy. That was a great presentation. And, there were just so many great points that you made to help support us as we age in life, and especially, when you're kind of wondering about dementia and is that something that's something I have to worry about, especially during my menopause journey. Um, some of the questions that kind of come to mind are, you talk a lot about the long COVID and the menopause, but are there other health conditions or changes that causes symptoms that are similar to the cognitive decline and dementia?
Yeah, there are many other conditions. So what we do when we're making a diagnosis of dementia is we're trying to rule out all things that are big, bad, and ugly, right? That we can intervene on. But some things that are maybe like generally like not so big, bad, and ugly, but if we let them go unchecked, they may continue to produce these symptoms for us, these cognitive symptoms and other symptoms. So, for instance, we're checking basic blood work for people who have some cognitive symptoms to make sure they don't have an electrolyte abnormality, they don't have signs of an infection going on, they don't have vitamin deficiencies, hormonal changes that could definitively explain the cognitive changes that are like so abnormal that they could explain that. That could be corrected pretty readily, any of those things, right? Another one is if you have seizure disorder, if you are reporting a history of like kind of blanking out or losing time now and then for like a minute or two, that's really suspicious for a potential seizure. Seizures are not always motor seizures, which are what we normally think about. They could just be electrical abnormalities happening in your brain, right? And those things can also present with some cognitive symptoms, but when you treat the seizures, that can help with that. It can help to recover some of that function. And so and I will say that the thing there is that seizures can also come on with dementia. There's a higher likelihood that you get dementia when you have epilepsy, and a higher likelihood that you actually get epilepsy when you have dementia. So it's still something to think about that like dementia could still be a part of this picture. I need to keep an eye on this over time, right? And I think that it's helpful for patients to know that. Like some people will say to me, like, why are you going to freak people out? Like, and I'm like, I'm not trying to freak anyone out, right? This is kind of how we think as doctors is like, let's think about the different possibilities and like, don't be concerned that you have that right now. Let's just keep an eye on it. Like there are plenty of people who have plenty of the conditions that I've mentioned, right? So like, you're not alone no matter what. And, there's a likelihood that you are not going to ever develop these things like dementia. But it's good to keep an eye on. We all have increased risk as we age, and certainly if we have these other risk factors, there are greater risks. So yeah, it is complicated, but there are these other conditions. If you have liver disease, also it can produce abnormalities that get reflected in the blood work often, and that can also show like that's maybe why you're having some difficulty thinking. It's because your liver is not functioning so well. Um, yeah, so different organ system dysfunction can certainly contribute to cognitive issues. I mean, we're whole human beings, right? So if we're
Right.
not wholly intact, it really can have influence over other parts of our function.
So it sounds like there are lots of different types of tests or labs or images or standardized assessments that can be done as part of a dementia workup.
That's right. That's right. It is usually, if you go to our website, if you have any concern about this, we have a free screening tool there and a staging tool, but it'll ask you the questions that we ask as consultants, basically, as neurologists, geriatricians, or geriatric psychiatrists often are making this diagnosis as well. PCPs can, but they often don't for a number of reasons. They will refer on to specialist care. And so when we do this workup, it is basic blood testing. It might be brain imaging. It might be an EEG, depending on the person's history, right? If they say like, oh, I've had a severe headache on this side of my head and it's new, and I'm having some cognitive issues, we probably want to image their heads to see is there
Right.
something there that might be explaining this. But if they don't have that kind of history, if they have a normal exam, like we may not do imaging of the head. Usually we do. We usually do imaging. We may not do an EEG unless they report by history that they have some kind of, episodes like I described.
Okay.
Yeah.
Do any of the symptoms present differently in women versus men?
Oh, that is a great question. And I feel like there is the question of whether they actually present differently and the question of whether they are interpreted as different.
Ah.
Uh, yeah, I mean, I just had this conversation with my daughter actually yesterday. She had gone to the doctor and we were talking about how women often get dismissed in the symptoms
Yeah.
that we report to our doctors. And it's maybe not that it's a different symptom that is being reported by us versus a man, but that the person receiving that is interpreting it differently, right? For a woman, oh, maybe it's that you're anxious or stressed out. And for a man, oh gosh, that might be actually a heart condition. Let me do that workup, right?
Yeah.
And so it's two different questions, I think. I've not read about presentation of cognitive symptoms being different between women and men. Um, so I'm not sure that that's the case. I think the second thing is very true. I mean, not just with cognitive symptoms, but with even somatic symptoms that women report to our physicians, unfortunately. I do think that there is a lot of that
Sure.
dismissing. Yeah,
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 and especially in the menopausal years, and you got to
absolutely.
wonder when should a menopausal woman go to be seen, to be assessed for dementia versus, a symptom like brain fog related to hormonal transition of the menopause journey.
Yeah, and that's where I say, like, if you are seeing a decline over time or some of those real red flags, like you get disoriented in terms of like where you are, you can't do the simple kinds of things that you were able to do before in terms of using like simple tools. Um, that's really not very normal. It's not a symptom of normal aging. And so I would be more concerned about those kinds of things. If they get worse, I definitely would become concerned about them. If they're severe, I would be concerned about them, right? Like, really, that impairment of independent function, I think, is pretty key. But the thing that's challenging about that is that often you're not impaired that much until you've progressed pretty significantly, right? So it's like that's where I say change over time. Like, look at change over time. And even at the beginning, you should be able to notice that and ask people around you, like, have you noticed that, like, I've asked my husband, am I repeating my stories more than I have before? Or did I already tell that to you? Like, tell me if I'm doing that because I might not have an awareness of that. And it's important. You can track that in a journal too. Like, this is when this happened, right? And then look over time. Am I doing this more often? This is concerning to me now. It's changing, right? Menopause, as I said before, is like for a discrete period of time, you may have that brain fog, but then you don't really notice it as much anymore, right? Like once you're beyond that period, a lot of those symptoms actually kind of work themselves out, and it's life is more tolerable, right? Like hopeful, joyful. Um, but yeah, so I think that's the major difference. And to be too overly concerned about it, I don't know that that helps. Like I think it's just to be mindful of it. This could happen. It happens more to women than to men. It happens over a long period of time. Maybe I have more risk for it because I have many people in my family who have this disease. So I just should be mindful. If any of those risk factors that I mentioned are unaddressed, I should be working on those now, yesterday, right? Like, absolutely. Like, for even with menopause, we have caregivers who are going through menopause and they're like, well, this is why I'm having this symptom. And I'm like, also, all of those risk factors for dementia you can be addressing, right? Like,
Right. Yep.
yes.
Well, this is fabulous. All this great information you've shared with us today, Dr. Murphy, we really appreciate it. And we here at Positive Health, we really like to leverage the power of webinars and podcasts to bring awareness to the various topics related to menopause journeys. And we do have a YouTube channel where we have all the recorded webinars out there for people to go view on a whole slew of different topics related to menopause. And we will be including this one as well here in the near future. So please feel free to go out to the YouTube channel. We have it's Positive Health, and look up some of the great topics and listen to them. And then also on our website, our positivehealth.com/webinars website page, we will be posting new webinars coming up, and you can enroll in those. And on the next slide, I am very happy to say that we've got Dr. Murphy, who joined us with a podcast series, and she was there again talking about tackling cognitive changes during menopause. And so she was very great in sharing even more information about this in our podcast series. And you can find that out on our website or any of your favorite podcast channels, such as Amazon and Apple and Spotify and iHeartRadio. And then, if you aren't a member already, or you know someone who may benefit from positive health, you can join our program for free for a limited time. And here you will find that holistic digital health experience supporting your menopause journey. So don't hesitate and join in now while you can. And with that, I would like to thank you for viewing this webinar, and a big thank you to Dr. Murphy for presenting all this amazing information that you did today. I think it's going to be very helpful for a lot of people to listen in and learn and help them with their future journey.
Thank you so much.
All right. Thank you so much, and have a great day.